بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين. أولا بشكر وحدة الإيميولوجي والروماتولوجي كلية طب جامعة المنصورة، كل الأساتذة الأفاضل وعلى رأسهم أستاذنا الجاد فازر لأساتذة الوحدة الدكتور علي يوسف. الدكتور علي يوسف هو الأب الروحي لكل أطباء المنصورة. أساتذتي وزملائي الدكتور إيهاب، الدكتورة دينا، الدكتور عادل عبد السلام، الدكتورة أسماء، كل أعضاء الوحدة على الدعوة للمشاركة في المؤتمر الناجح إن شاء الله رب العالمين.
معنا دكتورة أمينة.
I'm really very happy to introduce the next speaker. The next speaker is Professor Abou Raya. Abou Raya is a professor of immunology and rheumatology at Alexandria University. She is the ex-head of immunology rheumatology department in Alexandria University. Her title of presentation will be about cerebral vasculitis. I am sure all of us will enjoy the presentation. Professor Abou Raya, please.
Assalamu alaikum. Thank you very much, Dr. Ala, for this wonderful, kind invitation. Really, it's an honor and it's a pleasure for me to be amongst my colleagues and my friends in Mansoura. And I thank everyone in the organizing committee and in particular, of course, Professor Ihab for inviting me. It's a great honor for me to be here. It's a wonderful organization and it's a pleasure for me to be with you. I've been given the topic of cerebral vasculitis. Cerebral vasculitis, of course, is a rare disorder. But of course, it's increasingly recognized. We all know this, and we see this in clinical practice. We know that the CNS tissues are relatively inaccessible, and diagnosis is often inferential. We need to have a very high clinical acumen. We need to be very wise as doctors. Originally, of course, it's viewed as both highly fatal and often even sometimes uniform and sometimes not. It's recognized as being heterogeneous, and if treated early and detected early, sometimes we can help our patients. I'm just going to get rid of this because I can't. Okay. So what is cerebral vasculitis? Cerebral vasculitis, put very simply, is a descriptive term rather than a specific disease, refers to inflammation of within the wall of the central nervous system blood vessels. And as we all know, it's often associated with destructive changes, occlusion, and infarction. It may be classified as is well known according to the size of the vessel or by neuropathological findings. Also, it's classified according to the etiology, secondary when associated with other systemic disorders, such as autoimmune diseases or infectious diseases, or of course, primary CNS vasculitis when it is only restricted to the CNS. So this is the classification: primary angiitis of the CNS, confined only to the CNS; secondary, which we always have to exclude secondary disorders; and the reversible cerebral vasoconstrictive disorders. According to the vessel size, we have the large vessels, mainly speaking about infections and the primary CNS affection, as well as the RCVS. Medium vessels, more to the distal to the middle cerebral bifurcation, again, primary infections, systemic vasculitides. Small vessel disorders often affected by the coagulopathies and the infections. We all know in clinical practice that the diagnosis is very, very challenging because there's a broad differential and there's non-specific initial clinical manifestations. Differentiation between primary and the secondary is going to be very important because it's going to be important also in the treatment. We know that therapy, even to date, I've got no large randomized controlled studies to talk about. Most of the therapy up to today, it's guided by observational data. Mostly it's empirical. And despite the use of many targeted therapies, we all, at the end of the day, resort to glucocorticoids and cyclophosphamide as the mainstay of therapy. Of course, we have to agree that this is a team-based work, and without having neurologists on board and other specialties, we can't do much. In all of our specialties in rheumatology, there's a great progress, but nothing much has appeared in cerebral vasculitis in the past 2 or 3 decades. We continue, as I said, to have no randomized control trials. We continue to base our therapies on the 2 anchors, cyclophosphamide and corticosteroids, and we still have to have a very good clinical acumen, because that's what at the end of the day we're going to depend upon. If we quickly look at the primary central nervous system vasculitis, we know it's a rare disease. It's been described very late back in the 50s, and many names have been given to it over many years, including non-infectious granulomatous angiitis. The names capture 3 essential features. Number 1, the pathology, the transmural inflammation of the vasculature. It's limited, or there's no systemic involvement, and of course there is exclusion of all other inflammation. Leonard Calabrese in the States, as well as Malik, gave us the criteria back in the 80s. They said for us to diagnose primary CNS angiitis, we need a history or clinical findings of an acquired neurological deficit of unknown etiology after a very thorough clinical and basic assessment. The central angiogram with the classical features of vasculitis, or a CNS biopsy sample showing the vasculitis. And we need to have no evidence of systemic vasculitis or any other disorders to which angiopathic or pathological features could be secondary. So these were the proposed diagnostic criteria put back in 1988. We know that this is a disease classically affecting middle-aged individuals. It could be similar between men and women around about the age of 50. We have to have an extensive workup of the differential diagnosis. There's a very, very big list, as you see in front of you, of the differential diagnosis. But most importantly, we have to exclude 2 very important causes which will make very important decisions in our therapies, and that's infections and malignancies, because we know we can't give, in these 2 particular conditions, we can't give immunosuppressive therapies. So there's a very long, extensive list: infections, neoplasms, systemic inflammatory conditions, genetic conditions that we didn't know much about, including, I want to refer to you to the Cadocell syndrome. Cadocell syndrome is a genetic disorder where there is cerebral autosomal dominant arteriopathy with subcortical infarcts, and also associated with leukoencephalopathy. This is also starting to appear and should be at the back of our minds. So there's a very extensive list. This list goes on forever, well known to all of us. But as I said, infections and malignancies have to be always excluded, because these 2 are very important. There's now, in a paper that has just come out, has given us the 2020 proposed criteria. It hasn't been validated for the diagnosis of the primary. They say we should have 2 entities: definite and possible. Definite diagnosis is there when there is a clinical presentation suggesting CNS vasculitis, with exclusion of alternative possible diagnoses and of primary systemic vasculitic syndromes, plus the presence of a positive CNS histology, that is biopsy or autopsy showing the CNS angiitis, and that we know that it could be granulomatous, lymphocytic, or necrotizing. That's definite diagnosis. What we all go by in clinical practice, because none of us or most of us don't do a biopsy, is possible. Possible means clinical presentation compatible with CNS vasculitis after we exclude alternative possible diagnosis, plus only, that's what we do mainly in clinical practice, lab and imaging support for CNS inflammation, whatever it is, etc., elevated levels in the CSF, etc., or imaging such as the MRI. So this is the proposed criteria. 2020 has not yet been validated. We know that the clinical picture is very variable, wide range of manifestations in the primary, from acute to insidious. Many patients present with a headache, but of course the history of a thunderclap headache is virtually never encountered in a patient with CNS vasculitis, and should always prompt consideration of something very important that we all know, a common mimic, which is the reversible cerebral vasoconstriction syndrome, That's only occurs the thunderclap headache in this syndrome. Focal deficits, of course, are there, maybe related to whichever vessel is affected. And of course, systemic features such as weight loss, night fevers, rash, etc., should also prompt us to consider systemic disease. This is the pivotal paper done by Carlo Salvolani. He is very interested in cerebral vasculitis, and he did it back in the 80s, where he looked at the primary central nervous system vasculitis, and he analyzed 110 patients, wanting to look at what are the different presentations of these patients. And just recently in 2015, the same author did a similar analysis, and as you see, he just had 163 patients. From the 80s down to 2015, not many patients were added to his list. And he found that amongst the manifestations, headache is the most common symptom, either generalized or localized, together with cognitive impairment and focal neurological manifestations. Constitutional manifestations should make you go away from the diagnosis. But as you see, a very big list of manifestations with headache and cognitive impairment and focal neurological manifestations heading the list. Exclusions, as we said, should always be in our mind, particularly the infections, particularly the neoplastic, the paraneoplastic, not forgetting the Sjogren's, sarcoid, embolic phenomena, hypercoagulable states as well. And something which is so important in clinical practice as well is CNS lymphoma. Many patients present to the oncology with focal deficit, and CNS lymphoma could be the cause. The timeline, as I said, we've come some way, but what is increasing is that we are now getting molecular diagnostics. We're getting more better imaging techniques, indirect angiography. We are also knowing more about the genetic disorders. So this is increasing our list of the causes. Evaluation, as we all know, it should start as in any patient with a stroke. We should look for the causes. Cerebral ischemia, of course, in a young patient with a lack of traditional cerebral vascular risk factors is another cause that we should always aim for. When we have chronic meningitis without a demonstrated infectious or malignant etiology, and of course, a combination of unexplained focal or neurological deficit. So the workup should be like a routine stroke evaluation, ECG, echocardiography, looking at the risk factors, diabetes, risk stratification, etc. Looking also at the metabolic phenomena and the toxic workup in the patient. But all, we repeat, are non-specific. That is why acumen, clinical acumen is important. Sometimes we get a picture, and this is very often in clinical practice, which resembles multiple sclerosis, and the patients go about being diagnosed and having this label of MS or MS plus or pseudo-MS. So this is, again, one of the important differentials that we have to keep in mind, all non-specific. So we should take it on an individual basis. So investigations are important. Ocular examination as well is important. It helps us in getting some of the risk, some of the etiology more narrowed. Markers of inflammation are important. ESR, CRP, usually normal. If elevated, we go towards an infectious cause, as we all know. Serology is very important. Often it comes back all normal. Lumbar puncture is of the utmost importance to exclude, as I said, number one, infectious and malignant processes, and to rule out reversible cerebral vasoconstriction syndrome. That is very important. It's abnormal in up to 90% of patients. As you see, nothing is 100%. There's a lot of non-specific abnormalities. We have to put that into the clinical perspective of the patient. But one message is that CSF examination is critical. It's critical in the assessment of a patient with suspected primary CNS, and it should be performed in all patients unless there is some extreme contraindication. In addition to it being a prime means of identifying CNS infection, etc., it also has a very high negative predictive value for ruling out CNS vasculitis, and quite high, up to 95%. As we know, usually there is a lymphocytic predominant pleocytosis and or elevated protein level, but really can include also clonal bands or elevated CSF immunoglobulins as well. Neuroimaging is important, but when you always order it, know that it's not definitive, because no specific imaging finding is absolutely or adequately sensitive or specific for primary CNS involvement. And thus, the diagnosis cannot solely be made on neuroimaging. There's a lot of fallacies and a lot of resemblance. A number of ischemic and demyelinating processes can cause identical imaging changes. So MRI imaging is recommended for patients with suspected primary CNS. It demonstrates a high degree of sensitivity, but keep in mind there's a low specificity. So that's important to know. So the workup is, as we all know, it involves these elements: serology, CSF neuroimaging, cerebral angiography, and of course the gold standard. The gold standard is the brain biopsy. It's the brain biopsy, and many of us, of course, do not do it because it's invasive. Neurosurgeons sometimes do not want to do it. The yield sometimes is not enough. Here, in a review of 61 patients referred for brain biopsy for suspected vasculitis, an alternative biopsy, such as infections or neoplasms, especially in lymphoma, was diagnosed in up to 40%. So by doing a biopsy, you cut down the chase, as we say, because many people go around taking immunosuppressives according to imaging, and when the biopsy gets done, it's not a primary CNS anyway. It's either it could be an intravascular lymphoma. So biopsy is of course beneficial, and it should be done, but we should break down the barrier between us and asking for a biopsy and the neurosurgeon doing a biopsy. The barriers are still there around the world. Approximately 63% of patients with primary CNS present, of course, as I said, with the headache. That's the important classification. But it's important that when you do investigations, you always keep the differential in your mind. So brain biopsy, just once again, is underutilized. It's valuable. It's of course not 1,000% confident level, because we know that sometimes the tissue that they take is not enough, etc. But if it is done in a well recommended place, the two reasons to definitely that we need to biopsy is to rule in. That's a positive predictive value. And of course, we have to rule out conditions. So keeping a biopsy as in the differential investigations is important. It does give us a lot of information. Neuroimaging, as I said, there's a very big list: CT, MRI, SPECT, highly sensitive, non-specific. That's the problem. You have to put it all together. It's non-specific. There's no specific angiographic study that is 100%. But so what people saying now that angiography is a pirate's treasure and a fool's gold, because we know that there are many typical findings that we see: stenosis, ectasia, beading, etc. But sensitivity is not always there. So we have to keep that in mind. So brain biopsy is important. We need it. If we can do it, we should do it. We should keep in mind that imaging is important. It is not always sensitive. There's a lot of fallacies. Angiography is there as well, not always helpful. We have to put the clinical picture together. It can be misleading. There are new techniques that they are used, but the must rule outs always are infections. It's particularly what we see now: the viral infections, mycobacterium, and the malignancies, particularly CNS lymphoma and particularly intravascular lymphoma. The treatment, as we all know, nothing has changed. No direct trials. As we said, it's cyclophosphamide and corticosteroids. It's the mainstay of treatment. We can also add methotrexate, and we can also add other immunosuppressive agents such as MMF. It has also shown efficacy, and reports of rituximab are also there. Patients with primary should, of course, take an induction phase, and also should have, as we said, an induction phase with high-dose steroids, and also should go on to a maintenance phase. Patients that show resistance, we have other therapies now, TNF inhibitors, and also we have new biological agents that have still not fully licensed. Maintenance therapy, as we all know, should be long-term, and these are the drugs that we have for maintenance therapy, as a MMF or methotrexate. Always keep in mind, if your patient is not responding to cyclophosphamide and glucocorticoids and is not getting better, look for an alternative diagnosis. Don't keep on pressing the steroids and don't keep on pressing that he's got refractory disease. Look for an alternative diagnosis. It's quite important. Reversible cerebral vasoconstriction syndrome, it's an important differential. As I said, it comes with a thunderclap. This is a very nice table that differentiates between the two. The clinical presentation in the RCVS, it's an acute onset with a thunderclap headache. Usually the clinical course is monophasic, CSF is normal, neuroimaging could be abnormal, histology is normal, and of course the therapy is usually by calcium channel blockers. So keep it in your differential always, it's important. So in rheumatology, when are we faced? When do our colleagues tell us? Sometimes they tell us to come on board when they want more diagnostic reasoning, when they don't know what their case is. So there are many different scenarios where you could be asked to help your colleagues. This is the algorithm that we all keep in mind, the symptoms, the imaging that we have. Place it all into perspective and go down the algorithm slowly. CNS vasculitis, we know that there are many CNS, such as the connective tissue diseases, is particularly the systemic lupus. We know that CNS involvement occurs in 50% of our patients, and it's quite common. And the presentation could also be very variable. And here we know the association in up to 40% with secondary anti-phospholipid syndromes. Again, patients here do the extensive workup, and of course anticoagulation, steroids, immunoglobulin, plasmapheresis, and rituximab is on board. Sjogren's syndrome should not be forgotten. It occurs, neurological involvement up to 20%, and it can go undiagnosed. Rheumatoid arthritis, we know it can affect the CNS very rarely. We also have to keep that in mind. Secondary cerebral vasculitis is a rare complication, particularly in seropositive extensive rheumatoid arthritis. Also, of course, related to the systemic vasculitides, keeping in mind Bechets, of course, GPA, EGPA, and polyarthritis nodosa. 2 words just for Bechets disease. Neurobechets, of course, it can be found in up to 30%, particularly parenchymal involvement or meningoencephalitis is a common presentation, or cranial nerve palsies. Also, cerebral venous thrombosis and aseptic meningitis are very important non-parenchymal lesions. Important that they can mimic multiple sclerosis. So we know the treatments are out there. We have also recommendations, including steroids, immunosuppressives, as well as TNF blockers. Other options are there, such as tocilizumab as well. GPA, of course, we know that CNS involvement occurs in a big percentage. There are many pathological types. Don't forget polyarthritis nodosa, also important. And of course, the eosinophilic GPA, which is very important in about 10% of our patients. Once again, I reiterate the infectious arthritis is so important, especially the viral, the tuberculosis, intravascular lymphoma, so important to always to keep in mind, because this is a type which is rapidly fatal, and it occurs in elderly. We're seeing more of it. I have seen 2 patients in the last 2 years, and it was really a tragedy that we couldn't go on to help them. Cogan syndrome is also one rare form of systemic vasculitis that can have CNS affection. So therapeutic considerations are there. Induction of therapy, remission is also important. For the sake of time, I won't go into all the details, but I just want to end up by saying that we have a very, very big list of differentials. Keep in mind, the approach to diagnosis and management of CNS vasculitis benefits from a thorough, careful history, multidisciplinary integration of clinical lab imaging, histological data to identify the secondary causes. Collaboration is key, and the next decade, I hope, will continue to push us forward and to give us more and more better imaging techniques and better diagnostic modalities. I thank you for your attention.